Yeah.
May I call for your attention, please?
Yeah. Good afternoon, everyone, respected judges and my dear colleagues. Today, I'll be talking about an innovative do-it-yourself manual technique of silicone oil removal versus a machine-based approach. It's a comparative study, so I don't have any financial interest. The aim is to study the efficacy of manual silicone oil removal by a modified innovative technique as compared to a vitrectomy machine-based approach. Coming to the methodology, this is a comparative interventional case series with a total of 20 eyes.
Please maintain silence, please. The
Group A,
candidates who are supposed to present come forward and sit.
Group A had 10
Proceed.
patients undergoing SOR by modified manual technique. Group B had 10 patients with vitrectomy machine-based approach. The study was conducted from Jan 2023 to March 2023. All the patients posted for silicone oil removal without the need of any adjuvant procedures were included in the case series. Now coming to the vitrectomy-based approach, as you can see to the left, this is a short video wherein you can see the extrusion syringe which is connected to the vitrectomy machine. You can see the oil come out very slowly into the extrusion cannula of the silicone oil removal cannula, and along with this you can see the equipment which is required for this machine based approach. That means it requires a machine, it requires a cassette, the tubing, the extrusion thing. This is what is all required for machine based approach. Coming to our modified manual approach, so we just need a short end of a silicone infusion tubing which is connected to a 5cc syringe, that's it. And after that, coming to the procedure per se, we make 2 ports and the infusion comes from a saline bottle which is connected to the saline stand, and it comes to the eye with infusion tubing. Here you have a 3-way cannula. After that, ports are being made, and you can see manually the thing is pulled with your hand and it is connected to the eye, and you can see clearly in this video how better and how fast the silicone oil is being removed with the help of our innovative technique. And after that, the fundus is examined and partial fluid air exchange is done with the help of the sister injecting sterile air into the vitreous cavity, and we removing the partial fluid with the help of a flute needle. So the time taken for SR in both the techniques was noted along with any adverse events. The patients were examined on day 1, 1 week and 1 month. On follow-ups, the BCVA, IOP and the status of retina and any other complications were noted in either of the procedures. Now these are the results in our manual technique. First is the time taken with our manual technique. The second column has the adverse events, the BCVA, then followed by the IOP at 1 month post-op and the retina status. Now this is the results of our vitrectomy based approach. So in our study, the age of the participants were 49 plus or minus 4 years, 9 were male and 11 were females. Coming to the results, the preoperative BCVA ranged from hand movement to 618. All the patients had 1500 centistokes silicone oil. The important point here we should note is the mean time taken for SOR by our innovative technique was 1.92 minutes, whereas in the vitrectomy machine based approach it is 5.2 minutes. And the post-operative visual acuity ranged from 1/60 to 618. There were no intraoperative complications in either of the techniques. Now coming to the discussion, in very earlier eras, the silicone oil was removed with the help of passive extrusion with a sclerotomy port. Then after that, Garodia et al. And all gave us a 19 gauge needle vitrectomy machine based approach. Then Capron et al. Also advocated a technique of machine based removal with the help of a 25 gauge microcannulas. Now there are machine independent techniques which are being propagated by Zhang et al. And Zonglin et al., where they used a 10 ml syringe which is lifted up manually and the syringe is clamped. For machine independent techniques, they did tell that the vitrectomy machine approach had a slight advantage because of the controlled negative pressure, whereas the manual technique was faster. So what we did was the 10 ml syringe, which in the previous techniques generated a pressure of 676 mmHg, when it is pulled up to a mark of 4.5 ml and it is clamped. In our modified technique, we used a 5cc syringe which is safer, and the amount of suction which we generate is depending upon the plunger which we manually pull. So it takes away the need of assistant also to clamp the plunger end. Now looking at this time, everything we are talking about is carbon neutrality, how much less we produce. So the minimum usage of equipment is there in this, so there is so much less to reduce and recycle, so which will definitely make an impact by our innovative technique. So to conclude, our technique involves the use of minimal equipment such as sterilized infusion tubings and a 5cc syringe. It has been demonstrated to significantly faster SOR, at the same time efficacious. And very importantly, it may be used to perform SOR in ophthalmic institutions that are devoid of a vitrectomy setup also. To conclude, our DIY innovative technique for SOR is economical, safe, time efficient, and environmental friendly approach for SOR. Thank you.
That's nice. Thank you, Amma. Thank you, Dr. Ashok.
Sir, I would like to take any questions.
Since I'm not a retina person,
Yes, ma'am.
has this technique is something very innovative by you, or it has been done in besides some few
Yes, ma'am.
others or substantiated?
Yes, ma'am. We do have papers in which we have come along many modifications from what they have done, ma'am.
Yeah.
So it is not truly a completely innovative, but it is completely modified from what they do. In the papers what they have been presented, it has always been a machine based approach, because when we read through the papers, ma'am, in cases of SOR which they have done machine independent also, there were other techniques like using the machine in the cases they have done an SOR. So in our cases it's completely machine independent. So there is a huge innovative modification which we have done from the papers which have been presented. So what we felt is, not many people where we can do it really fast and really. So we thought, sir?
How early on this silicone oil has to be removed? Like, would it be of use for oil if it is to be removed much later? Would that also come easily?
Ma'am, it would be beneficial for every time of silicone oil removal. Generally,
it's emulsified oil into those kind of.
Exactly, ma'am.
Yeah.
That also machine independent. We can just use a small flute needle, if it is emulsified, to take out the emulsified bubbles, ma'am. So this technique, from a early silicone oil removal to a late silicone oil removal, it can be done completely machine independent and easily.
Thank you. Thank you. Good.
Thank
Good
you, Dr.
presentation.
Ashok.
Thank you, sir.
Dr. Yedala Divya, please come over.
What is the time duration? 6 minutes.
6 minutes only.
Good morning everyone. I am Dr. Divya from Vision Eye Hospital. My topic for presentation is hitting the bullseye, the role of intrastromal voriconazole injections in deep stromal fungal keratitis. The scope of my presentation includes introduction, intrastromal vosal procedure, study and conclusion of this study. Mycotic infections are responsible for nearly half of the cases of culture positive infections in developing countries. TST protocol provides a systematic algorithm for treating fungal keratitis of varying severity. Initially, we start with topical natamycin and 1% voriconazole, and we add systemic antifungals in the form of ketoconazole or voriconazole in ulcers greater than 5 mm and in depth greater than 50%, or if there is any impending perforation. If ulcer still doesn't respond, then we go for a targeted therapy in the form of intrastromal and intracameral antifungals. But deep stromal keratitis still poses a challenge, as there are several limitations for the currently available topical medications like pore penetration, surface toxicity and limited spectrum, which leads to non-healing ulcers and land up in keratoplasty, which is limited by factors like graft rejection, reinfection, limited availability of donor corneas in our country. So targeted therapy in the form of intrastromal antifungal form a depot of drug near the ulcer, which leads in better healing, thus avoiding the need for therapeutic penetrating keratoplasty. In this study, voriconazole was given as a targeted therapy. It's a prospective interventional case series conducted at Vision Eye Hospital, Visakhapatnam from August 2022 to August 2023. 8 cases of microbiologically proven fungal corneal ulcer that did not respond to conventional therapy over a period of 2 weeks were included in this study, and depending upon the severity, multiple injections were given sequentially, and the patient was followed up for every 5 days, and the healing was documented with serial slit lamp imaging. Coming to the procedure, ozol as a preservative form is available as a lyophilized powder, 1 milligram lyophilized powder in a glass vial. It is reconstituted with 2 ml of distilled water to reach a final concentration of 50 micrograms per 0.1 ml, which is loaded in 1 ml tuberculin syringe with a 30 gauge needle attached. So this is a video showing the procedure. Needle is inserted obliquely from with a bevel up from uninvolved area to the area of corneal abscess, and drug is injected, and the amount of hydration is used to assess the area which is covered. And once the desired amount of drug is injected, capillary column is broken. Then the drug is given in the form of 5 divided doses, which form a barrage of antifungal around the ulcer. So these are the results. We have given intrastromal voriconazole in 8 cases, age ranging from 17 years to 60 years. Out of 8, 6 are males and 2 are females. Majority are mid to deep stromal, requiring multiple sequential injections. And out of 8, 6 healed well with good visual acuity improvement, and 2 went for therapeutic penetrating keratoplasty. So intrastromal voriconazole comes under targeted drug delivery, which is safe and effective way to treat deep recalcitrant fungal keratitis, thus reducing the need for therapeutic penetrating keratoplasty. These are the pre and post injection pictures. Thank you.
Thank you, Amma. Thank you very much. దయచేసి చప్పట్లు కొట్టండి ఒకసారి అందరూ.
What is the advantage or the topical medication of antifungals?
Over topical medication.
So it's a targeted drug delivery, sir.
Yeah.
So injection is depot near the ulcer, sir. So better bioavailability of the drug to voriconazole, which is at the site, leading to better healing of the ulcer. No, sir. Actually, not responding cases we have taken for
Only 8 cases.
8 cases.
That's all. Right, thank you.
Thank you, sir.
Bhavika Panchal. Is it, am I correct?
Sorry?
My pronunciation is correct? Your name?
Bhavik. Bhavika is the name of
Please,
the-
please, proceed.
So good afternoon everyone. I'll be presenting about anti-segment overload diagnosed occult scleral tear as a novel non-contact, non-invasive technique. So if you look at these 3 pictures here, right, we have a eye with subconscious hemorrhage which is resolving post-corneal tear, and we have a conjunctival laceration. What is common to all the 3 cases? It is a suspected occult scleral tear. So can we predict which case will need an intervention? Right? The answer is difficult unless we take up the case for surgery. So let's look at the cases in detail. This is a case 1 where the patient denied any history of trauma. Patient was not aware, but diminution of vision of 1 week duration, hand movement vision, and you can see the pupil is mid dilated, AC is deep. You cannot see it here in this picture, right? And when we went ahead with the B scan, there was a retinal detachment which was noted. So why this patient developed retinal detachment was the question. So amongst the subconscious hemorrhage, there were few dots which were noted, which was unusual. It was like depression in the sclera. We went ahead with UBM, and to our surprise we found that there was a scleral defect with vitreous incarceration. However, it was easy to do the UBM in this case, and we thought let's explore our thought process further. We went ahead with the anterior-segment OCT. It shows a very nice, well-demarcated scleral tear with the overlying intact conjunctiva and the vitreous incarceration into the tear. Same thing here on the different scan as well. Right, coming to case 2. Again a 12-year-old girl, a blunt injury 2 days prior, hyphema, AC inflammation. If you look at the multiple areas in the eye, you had a superior conjunctival laceration. Now we need to induce the child to explore whether there is any occult scleral tear present or not. Right. So we went ahead again with the anti-segment OCT, and we realized that apart from the conjunctival defect, you had a full thickness scleral tear as well. So this helped, and from that area you had a foreign body which had entered the eye as well. Right. So I'll come to it, the significance of this. Coming to the third interesting case here, this case was post-corneal tear repair. This patient had a history of recurrent anterior-segment inflammation. The vision was so whatsoever maintained. You had a nevus here, but I was not sure of the area here because of this. Whenever you have a recurrent inflammation, suspect a foreign body. The gonioscopy did not show anything. We went ahead with the anti-segment OCT in that area. To our surprise, we see a brilliant back shadowing here, suggestive of a subconjunctival and maybe intrascleral here of a metallic foreign body which was noted. Correct. So these are again a very not so common indication, but really helps, especially for occult scleral tear cases. We had 6 cases. There was a good correlation between anterior segment OCT, UBM, and also intraoperative findings. Based on the findings which were noted in the diagnostics, the surgeon also found it was easier for the surgeon to locate the tear and manage the child. Right. So to conclude, anterior segment OCT is an important non-invasive, that is no contact is involved as well, diagnostic model to diagnose occult scleral tears. In children, it's difficult to perform UBM in all cases. If the globe is soft, again difficult to perform UBM in such cases. This is a very easy tool. It has not been published before. It gives a confirmative diagnosis of occult scleral tear which could have been easily missed. Increase the predictive value or the positive predictive value in diagnosing such tears. Limitation is, yes, of course, beyond the spiral of Tillow it cannot image, right? So surgical exploration cannot be replaced. It remains the confirmative diagnosis. Anti-segment OCT can be an important non-invasive diagnostic modality to confirm the diagnosis of an occult scleral tear. Again, the rate of surgical exploration can be reduced by such non-invasive modality which can be performed in an OPD by anyone, especially for children where you can avoid a general anesthesia for such children. So thank you so much.
What exactly you mean by occult scleral tear?
So occult scleral tears are tears which are defined where there is no obvious conjunctival laceration or a perforation. The IOP may be normal. Mostly it is hypotony which they present with. Patients have a deep AC. They have vision loss. Was there a trauma or not? Because sometimes if I'm driving on the bike and one small particle just goes inside my eye, or I'm a bystander, someone is hammering and that can go inside. Occult scleral tears. Normally we do ahead. Yeah. So full thickness tears, you have important tear here, right? You have congestion which is going beyond the boundary and you cannot make out the posterior tear. Another occult scleral tear, when the patient is not aware, they can come after a gap of few weeks or months, right? Where the vision is women, we see no one is there to take them and take them to the hospital, and they don't complain. Such eyes, rarely you can have a neovascular glaucoma that can set
Not the
in.
neovascular aspect.
Yeah.
Early
IOP will be normal, but hypotony will set in
Hypotony
gradually.
is
Hypotony
likely.
is something.
because
Hypotony.
here he is saying that occult.
You are mentioning the word
Occult.
Yes.
There is no.
Occult. Exactly hidden. Yes.
That is
With
what. That is
subconjunctival.
why. No, the crux. No. What I'm trying to say is he's telling
Yeah.
it is an occult injury could get missed.
Correct.
So what? When you see a
Conjunctiva,
subconjunctival
pupil.
membrane, it is means that we go further and investigate,
Correct.
and that it could be a deadly scleral tear which is sitting
True.
there.
Exactly.
Or
It can be very
something
linear
which is
tear.
obvious is easy to
Yeah.
diagnose,
Yes.
but something
But
which is
here
not
we-
obvious.
Thank you
But
so much.
we have to monitor the IOP also for the
No. Monitor.
early post-traumatic glaucoma.
Yeah,
Absolutely.
going to be low in this
Yes.
particular case. There's
But
going to be
after
hypotony.
No. IOP will be low.
Post surgery will
Once
take
there is a-
care.
It's not definite perforation. Occult.
Sir, I'm trying to say that if you're not able to see it clinically,
See,
that is where you do
clinically
an
it's called
OCT.
occult.
If it's
No,
there
if
or
it
not,
is
you get an
Occult is
idea.
something.
No, if
it
it
is
is-
not a direct diagnosis. It was a diagnosis which
Yes.
something leads you to it, and then you diagnose it.
If
Correct.
it is a direct, decisions.
We don't
there
have to
are
go
other
through all
signs
these
by
things.
which you can find out.
If it's direct, we don't have to go through all these things. We have this in front of us. Yes.
What made you to go for anti-segment OCT?
Because we have the OCT in front of us. That day the patient had UBM.
He's having the instrument. with him.
So we wanted to do something
no.
innovative, right?
No.
See, what
Huh.
made you to go for the anti-segment OCT?
Correct, sir. That's what I'm trying to say. When the patient came to us, UVM showed that. We were like, okay, in this area, where is that tear? And we
Yeah.
got this. This was the first patient. And we realized, okay, this is something new which we can do. We did it for another 6 cases and we found very good results. That is why we are presenting here.
So without any intervention, these things have cured them.
No, no, they were all scheduled for surgery. You have a tear for all of them. You need to operate.
You have to take a courses.
Yes, yes, yes.
Right,
Sure.
thank you, doctor.
Thank
you
you.
very much.
Thank you.
మరి ఇది అపర్ణ, డాక్టర్ అపర్ణ.
Next is Aparna.
అపర్ణ.
Interesting.
Please proceed.
Interesting cases. Each is different.
Good morning everyone, this is Dr. Aparna. Hereby presenting the role of peribulbar bupivacaine in post-operative pain management after scleral buckling, a randomized control trial. Coming to introduction, the pain management is a very important aspect of patient care in all the medical specialties. However, it has taken a backseat in ophthalmology as most of the surgeries we perform involve less amount of time and very less tissue handling. However, there are some specific considerations to vitreoretinal surgeries. First one is the duration of the surgery. Depending on the surgeon's learning curve, whether he is a new or experienced surgeon, these surgeries can take up to a time period of around 30 minutes to 4 hours. Also, as more and more time it takes, both the patient as well as the doctor undergoes fatigue. Also, the surgeries in the vitreoretinal surgeries involve significant amount of tissue handling, mainly the retinal detachment surgeries, which involve tissue dissection, muzzle tagging, buccal placement, cryopexy, and endolaser. Every individual patient has a variable level of threshold for the pain. Hence, pain management should be tailor-made for each and every case. Coming to the aim of study, my aim is to compare the efficacy of conventional analgesics with and without peribulbar bupivacaine for post-operative pain management in patients undergoing scleral buckling surgery. Primary outcome measured was the patient's pain score comparison within first 24 hours of surgery. It is a double-blinded randomized controlled study conducted during a time period of 1 year. My inclusion criteria are the patients of 20 to 80 years of age undergoing scleral buckling with cryo with or without SRF drainage and 240 uncerclage band with vitrectomy. And these are my exclusion criteria where patients who are allergic to local anesthetics or liver, kidney or cardiac disease are excluded. Using the block randomization method, we randomized the patients into 2 groups. Group A received peribulbar bupivacaine at the end of the surgery along with routine post-op analgesics. Group B received routine post-op analgesics alone. Additional analgesia, that is intramuscular injection of diclofenac or any anti-glaucoma medication if required, is given in both the groups. Post-operatively by a blinded assessor, the pain was assessed at 3, 6, 12 and 24 hours using visual pain analog score. Any episodes of vomiting and use of rescue analgesics are noted in first 24 hours. All the surgeries were performed by a single surgeon under 10 ml of peribulbar block, and the duration of the surgery was from 30 minutes to 1 hour 10 minutes. At the end of the surgery, the group A patients received 5 ml of bupivacaine injection by the operating surgeon, and after the injection, the IOP was checked digitally. Both the groups received a routine post-op analgesics, which is a combination of ibuprofen and paracetamol every 12th hour. This is the visual pain analog score which we used. It was explained to the patient in the vernacular language and was asked to give a number. Coming to my results, a total of 72 patients were included in my study, 36 in each group. This is the mean age percentage of men and women in both the groups. Out of 72 patients, 8 patients underwent scleral buckling procedure, 64 patients underwent scleral buckling combined with vitrectomy. These are my results. Here we can see that the mean of the visual pain score at a time period of 3 hours after the surgery in group A and group B. You can see that there is significant difference between the values, and also which our p-value is also statistically significant, which is p-value less than 0.001. Similarly, at 6 hours also we found that there is a statistically significant difference between the mean pain score. However, at 12 and 24 hours, we can see that the value in group A and group B is more or less the same, and the p-value is not statistically significant. Here we can see the number of patients in group A who received rescue analgesics and who experienced nausea and vomiting are in less in number when compared to group B patients. Coming to discussion, pain, nausea and vomiting are the most common things which we hear from the patients in first 24 hours after the vitreoretinal surgery. The high incidence of postoperative nausea and vomiting is mainly because of the handling of the extraocular muscles, tissues, high buccal indent or increased intraocular pressure due to tamponade. There are many previous studies which are done and have shown that the bupivacaine block was effective at the, in reducing postoperative pain. But however, in these studies, the surgeries were performed under general anesthesia. In our study, we used a peribulbar block under which all the surgeries were performed. Bupivacaine group showed lesser pain score, which is statistically significant at 3 and 6 hours, and fewer patients needed rescue analgesics in first 24 hours of surgery. In first 6 to 8 hours, this bupivacaine group showed a good pain relief. The pain experienced by the patient triggers the vomiting center, which in turn activates the vagus nerve, which results in emesis. As a result of emesis, the patient experiences gastritis, because of which he will be intolerant to the routine post-op routine analgesics what we give to him. Hence, what we try to do is to break this pain cycle with the help of bupivacaine block at the end of the surgery. And I want to conclude my presentation by saying that use of bupivacaine at the end of the surgery has significantly increased the quality of post-operative patient care, especially in the first 6 to 8 hours. Bupivacaine block reduced the need for rescue analgesics and also reduced the incidence of post-operative nausea and vomiting in the patients. Thank you. These are my
Thank you, Dr.
references.
Aparna. Is it a routine practice to give peribulbar bupivacaine?
This is what we are recommending, sir.
Is it a routine practice? Anywhere it in textbooks is given?
No, sir.
No textbook.
There are articles, publications.
Any other person done this study?
Sir, there is a study which is done, but what they have, Sonia Mehta et al., which was done in United States, where they have compared bupivacaine with triamcinolone in one group and bupivacaine with a placebo. There they have study mentioned that there was no significant difference in the pain score, but the need of rescue analgesics was lesser in group A, where they have used triamcinolone.
The pain tolerance will vary from person to person.
Yes, sir.
So did you consider that point while grading the...
Sir, what we visual pain score to the patient. It is his level of this thing. He gives a number according to whatever he feels.
No.
No, thank you, Dr.
Good,
Aparna.
good presentation.
Thank you.
Last speaker.
Last speaker?
Vivek Nandini.
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 Nandini. Please come over, doctor.
Good afternoon, everyone. The topic for today's presentation is rate of IOL decentration in manual small incision cataract surgery and their visual outcomes performed by fellows. There is a continuous need to provide more cataract surgical services in developing countries. Ophthalmology residency programs play a very important role in training the surgeons. Various studies have shown an inverse relationship between the number of surgeries performed by a resident and adverse surgical outcomes. So there is a need to understand the relation between resident surgical experience and adverse surgical outcomes in manual small incision cataract surgery. The aim of the study is to analyze the rate of IOL decentration in manual small incision cataract surgery and their visual outcomes performed by fellows. This is a retrospective cohort study performed from May 2022 to May 2023 at a tertiary eye hospital in India. Re-surgeries performed for indexed manual small incision cataract surgery by fellows based on their surgical experience were evaluated and categorized into 4 groups. Seniors, that is, who had a surgical experience of more than 1 year, juniors, those who had a surgical experience of less than 1 year, and those who had a prior surgical experience of having performed less than 100 SICS surgeries and more than 100 SICS surgeries. And this was analyzed using computerized database. Resurgeries done within 30 days of surgery were captured and analyzed. Coming to results, we have evaluated a total of 3,957 SICS performed by 12 fellows. The overall resurgery rate was 1.16%, and the resurgery rate among seniors was 0.93%, and among juniors it was 2.17%, This showed a statistically significant difference between these two groups. And the resurgery rate among those who had a surgical experience of less than 100, it was 1.29, and those who had a surgical experience of more than 100, it was 2.19, did not find any statistically significant difference between these two groups. We have seen that IOL decentration, which went for IOL redialing, accounted for 24% of the resurgeries. And more interestingly, we have found that two more categories, that is AC wash and cortical cleanup, accounted for a greater percentage of the resurgeries, that is 28% and 26% respectively. And 86.9% of the cases which underwent IOL redialing had a post-op visual acuity of 6/12 or better, and 13.04% of the cases had post-op visual acuity of 6/18 or worse. Coming to discussion, SICS is the most commonly performed cataract surgery in developing countries. It is less expensive than phaco and delivers comparable outcomes. Haripriya et al. Shows a resurgery rate of 1.17%, which is very close to our study. Schmidt et al. And other studies show 0.85% and 1.9%. Their study was on phaco emulsification. Our study shows similar rates in SICS performed by fellows. Haripriya et al. Shows a declining trend with increasing surgical experience. They showed a lower rates after performing more than 200 surgeries. Similarly, our study shows higher rates in juniors than seniors, but there was no statistically significant difference between the groups who had a prior surgical experience of more than 100 and less than 100. Probably this can be due to assignment of least complicated cases, which was segregated pre-operatively to the inexperienced surgeons and continuous supervision by the senior surgeons. Haripriya et al. Shows cortical cleanup and IOL redialing as most common resurgeries done. In our study, IOL redialing was the third most common, the first and second being AC wash or wound reformation and cortical cleanup. Wound reformation, most commonly seen among juniors, probably due to improper wound construction. Cortical cleanup, most common among seniors, probably due to assignment of complicated cases. To conclude, manual small incision cataract surgery is a safer technique for early and inexperienced surgeons in a developing country. Resurgery rates show a declining trend with experience among the training surgeons even in complicated cases. The limitation of our study, the total number of complicated cases which are done during this period by fellows were not analyzed.
Which institute you have worked?
Sorry,
Which
sir.
institute?
Sir, SV Arvind Eye Hospital, sir.
What is the time frame you have studied?
1 year, sir.
Retrospectively.
Retrospective study, sir.
Good. Assessing the surgical skills among the senior surgeons is a great task. But you have done it good.
Thank you,
Thank
sir.
you.
Thank you, sir.
I think all of us can clap. You're so few. Delivery of the talk was very self-confident, and there was content, and there was not even a minute we could go mentally get diverted, and we were totally glued onto it, and it was difficult to score all of you. So to our minds, all 5 of you have done very well. Okay?
Thank you very much. Thank you, Amanda.